folks. I'm Adam Mariano, President and GM of the Healthcare Division of LexisNexis Risk Solutions. And this is our podcast, Healthcare DataWake. We all know that the American healthcare system is struggling to serve everyone equally. In many ways, it's actually broken. There's a long-standing bias and a lot of disparities in how patients access and receive care, and there are inefficiencies everywhere across the system. As patients navigate this system, like a ship going through the ocean, they generate two waves. They generate a bow wave at the front of the boat, if you will, and then they generate a stern wake at the back. And these waves precede them and trail them through their entire experience in the American healthcare system. This data is often treated as runoff or data exhaust, meaning that it doesn't really get processed in a way that can start to predict how patients may cut a path, or consumers for that matter, may cut a path through the system, and how we may actually help them by analyzing this data. And the whole point of this podcast is to talk to folks who figured out better ways to start to digest both the bow and the stern waves associated with this, hence Healthcare DataWake. Over the path of this podcast, we're going to look to talk to folks working in the healthcare technology spaces and get a real understanding for how they're starting to leverage this data in new ways, but also how the underlying infrastructure is changing over time to make it more accessible to everyone. My guest today is Flavio Villanustre. He's the CISO at LexisNexis Risk. So not only do I get to talk to him every day about work stuff, but finally I get to sit down and talk to him about his real life. So Flavio, thank you for joining us today.
Adam, thank you very much for having me here.
We're really happy to have you here. And I know I come and bother you all the time about things we're trying to do in healthcare. And it's an interesting space now where as all data is becoming consumer data, right? And we talked about this a bit. You're now starting to see healthcare and the utilization of that data and patient access and ownership now intersect and maybe even come into conflict with security and struggles to keep that data safe for folks. And it's sort of an interesting thing. And I, having looked at this data for a very long time, you look at the FHIR standard, which has now been around since 2012. Right? We've been through 4 iterations of it. It's now ubiquitous. I would say since I've been doing this work for 25 years or so, it's the first time we had a real standard. And it creates this now effective way to create portability. It's not just in name only, it's being used in all the systems. The federal government requires it to be used. It's being used in research. It's being used for patient applications, and certainly all the consumer apps you keep on your phone. It's now sort of a sea change in thought, where this was all locked up, and now it's sort of maybe overly accessible. What are your thoughts about what the change represents, but B, how we have to start thinking about this a little differently now? This data is in patients' hands.
Yeah, I think that those are important points, Adam. The approach to patient data and healthcare data in general has changed significantly, I think, for the good, for the most part. Yes, you're right that now that we generate such volumes of data, controlling that data in a way that is effective and that properly protects the privacy of the patients and puts the control on the patients on their own data. Those are all challenges that we are still trying to resolve in many cases. But certainly, I think it's good overall. In the past, you had patients that they went to a doctor, they got a primary opinion, and they wanted to have a validation of that opinion. They went to another doctor, and then suddenly they were asked to go and repeat all of these tests that they already did, just because the data was not available, right? That was absolutely horrible. So I think there is a lot of positive in the way it evolved. But of course, as long as we can guarantee the safeguards that will protect the privacy of those people and that the control over their own medical data is still in their hands, that's the important piece.
Yeah, I would agree with you. It's the portability thing is magical, right? And it all this started, obviously, Cures Act really pushed a lot of this in the U.S., making sure that patients could move from doctor to doctor without a lot of friction. And also, to your point, not replicating the costs, the time, the energy, and the risk of having to repeat testing, of having to try to reconstitute records. And there's still processes that ship around paper records, right? People literally create a PDF of all the records, and someone then has to try to parse it on the other side. So,
Unfortunately,
yeah.
yes.
And so now we have the ability to use that data from a systematic perspective because it can be shipped in FHIR, it can be parsed, it's actually standardized. It's a real opportunity. But I think from that perspective, now that we have new consumers who have access to this wealth of information, but we have a very broad variance in people's, not in health equity, but also in people's health literacy. And so
Of course.
most patients don't really understand what it is they're seeing in their chart. And it's one of the most forgotten components of health equity is the fact that most people don't really understand what the full record represents. What does this test mean?
That point is absolutely on the spot. So I still don't understand why we ask patients to sign consent documents of things that they can't understand. How can they consent to something that they don't know what it is?
Yeah. And that's an interesting one, right? And now that there is a standard, the reality is a consent document could be auto-generated from a federally required standard that was driven out of code set and some educational materials, much like they do with consent for clinical trials. There's a workflow where you might see a video and read some paragraphs and have to answer questions as to whether or not you understood the content. And I think we're at that place. But it's interesting. So we have a sister company, Elsevier, right, who produces a lot of patient education materials. And the reality is there's a whole breadth of information that patients can have digested and put into the same apps that share the data. They should also have access to some data. It may even be a requirement that they can read about that new condition. So I see you've been diagnosed with diabetes. Would you like some information about your condition? I was sharing. I had been navigating with my family for a year and a half. Someone in my family has had got diagnosed with cancer, had to go through treatment and a bone marrow transplant, and they have access to the healthcare portal. And every time they look at a new record that they're concerned about, they call me. And as one of the only people in the family with healthcare background, I'm often in that position of explaining it. And I'm glad they have me as a resource, but I think about all the other people who don't.
Most people don't.
Most people do not. And so it begs the question, should we be giving all this data to patients unfettered, right, without any filters and without any guidance? I don't know. What are your thoughts about that?
That's a great question. So, and I can see both sides of the picture here. On one hand, patients are really the owners of their own data, and therefore they should have full access to their data. However, the data needs to come, as you said before, with education attached. So yes, you see the value of your glucose in blood, but this is the education. These are the normal. This is what it means to have this value here. I think that is key. Now, of course, you can't force people to read or to learn things, but at least you can give them the opportunity, which is sometimes lacking in many cases, right? Yes, people might have access to their charts and to their results, but they don't even know what they mean, and they either get alarmed, in some cases to the extreme. On the other hand, having the knowledge, having the ability to learn what that means might even position them better to treat that condition. It is about the patient being able to own their own medical situation and address it.
Yeah, I think you touched on two pieces. One is, and it's funny, a lot of the projects that I've been engaged in over many years have been around lab data. And so one of the thresholds that was set in a lot of those projects was they would never release preliminary data to patients. They would only release final results because the preliminary results change. And so people panic over something they see in a preliminary result, but don't have the full wraparound read from either an oncologist or somebody else in the full results. So that one helps. But I think the other side of this is really truly about ownership, right? So it used to be, even though patients theoretically own the data, the only place you could really go to get it was from the health system. You had to go to a paper chart or to the EMR with no access to get data. And even though these rules have been on the books for a long time, now it's finally the time that everybody can have this on their phone. But it doesn't mean that the patient is the only person with that data. So as we think about that ownership record now going forward, the reality is patients now can carry that data around with them. And there have to be people who advocate on their behalf to teach them, A, to understand the data, but then B, to keep it safe. Because if it is on your phone and it's unlocked, or it's in a fitness application that wasn't vetted by the store you downloaded it, like don't sideload up applications. I'll just say that as a public health announcement. Don't sideload applications to your phone. The reality is there's now a new stake in ownership that patients have to take in caring for themselves or their family's data. and managing some of that security concern. And I had raised this when we had prepped a little bit about talking today. Was the last time I went to Whole Foods to buy some stuff, they had the palm scanner next to the checkout counter. Right? And this is not to disparage Whole Foods or Amazon, but it's very convenient. You can link a card that you use online, and it knows that's your account, so you don't even have to pull the card out of your pocket. You can say, yeah, sure, press this button, use that card that's linked to my account for this purchase. But then what you can also do is enter your palm into a bioscan that is now in the database, including your fingerprints, with Amazon, and now that can be used. And that one felt like a bridge too far to me. I was like, there's no way I'm putting my hand on that scanner, even if it's convenient, where I could scan in and scan out. I mean, I like the walk in, walk out technology, but that's tied to my card or my Amazon ID. But this is now biometric, which feels like we're stepping over the fence. And look, my phone has a thumb scanner on it, and we're in this place. What do you think about that? I mean, they're two-factor, but creates a whole lot of risk, right, from a collection perspective.
It does. So, and you pointed out of the real problem, right? This is so pervasive today. You use biometrics so much. Retinal scanners and iris scanners are not that popular because they require some closeness to the eye, right? So be able to capture the image. But fingerprint scanners are widely spread, even on your phones. Palm scanning is as you've seen it, quite used out there, and even capturing live pictures of your face and all that, right? So that can be used as biometric as well. Yes, there is a convenience factor on one side because some of these factors can be quite strong. Iris and retinal scans in particular, they have so much variation across individuals that they are almost guaranteed to be unique. So much more than fingerprints. Therefore, even though a fingerprint in a population with a few million people are unique, retinal scans might be across billions of people. They are unique. The only challenge there is that unfortunately, you cannot replace your eyes, right? So once your retinal scan is published or is breached by some bad actor, there is no way to put the cat back in the bag. Same thing with your fingerprints. The same thing with anything else, with your DNA, the DNA analysis or anything like that. So unfortunately, yes, this might be good ways from a security standpoint to do proper identity validation. And look, from that standpoint, these are great. But on the other hand, we need to ensure that the access to this type of data is controlled in a way that it doesn't become then a big problem down the road for those individuals.
Yeah. I like to think of this stuff the way we think of tokenizing data. Is where's the ability for us to start hashing fingerprints and retinal scans and other things so we can use a surrogate key that is not that record, but is still deep enough from an identification perspective that it can't be replicated. So still unique, but that feels like an opportunity.
Yet another great point, Adam, because that's exactly what many of these systems do. When you use the fingerprint scanner on your phone, the fingerprint scanner, the chip itself will get your fingerprint, the image of the print. But from there on, all that is representing that fingerprint is a series of mathematical vectors of where the main points are. And that's only what is exchanged. So there is a little bit of a protection there. But of course, that doesn't mean that someone using those cannot potentially forge a fingerprint that matches. Same thing with their hash. And that doesn't mean that someone cannot eventually compromise the chip that is reading and then inject something that will allow them to extract the full fingerprint as well. So there are still some potential security risks. Look, nothing in life is risk-free, just saying. We try to minimize the risk as much as we can, and by doing so, we reduce that risk significantly, but there is always a residual risk.
So, Flavio, when we talk about making better opportunities for patients to leverage their data and to make it more portable, one of the things we always think about, especially as we talk about the security side, is how to make sure that while we're helping them secure it and critically locking it down, right? That's classic CISO phrase, lock it down. How do we reduce the friction associated with that process and balance that with security? So it's a complaint of customers all the time that whenever you add security to a process, that it creates friction. It's going to reduce the ability of a process to be viable. It's going to reduce the revenue. It's going to reduce the patient or the consumer experience. And it's going to create, you're going to lose people and drop out of process. And I'm sure you get this complaint constantly in your job every single day.
It raises the barrier of entry,
Yes.
definitely. So yes, you're friction. You're adding friction.
Right. And so how do we balance that risk versus friction or security versus friction effectively in a space where we're now having this blossoming of patient data that's showing up in a space that was never accessible to patients before?
That is a very good question, Adam. And unfortunately, because of the type of people that you need to serve in this space, which essentially is everyone at any ages, if you need to add friction, and yes, in some cases when you add security, you add additional friction, that friction is not such a significant hurdle that will prevent them from accessing that. Otherwise, your attempt to give them access will backfire. But on the other hand, as you mentioned as well, there is a balance there. And the balance is, well, if I don't add enough security controls around these systems or these booths or this data access point, an attacker could compromise that. We can learn a little bit of this from other industries as well, because this is happening today. Just for the audience, attackers typically are not very discriminative about what they access. They don't have a special industry that they want to tackle, or they don't have a special victim that they want to compromise. They want to, in many cases, make money. That's it. And they do it throughout any place. And as long as they can find an easy way. So if the easiest way for them to get access to the data, they will do that. This is like what you do when you install an alarm system at home and then put a sign outside that says this home has an alarm. The sign is not going to prevent someone from attacking your home or compromising or breaking into your home or anything like that. It's just dissuading the attacker so they can go to the home next door that doesn't have the sign. Right. That's pretty much it, right? Same thing everywhere else. In other industries, especially those that manage a lot of money or financial records or financial assets, like financial services, we've seen how security became front and center for almost everything they do. It is true, and again, as an ex-medical doctor, I can attest to this, that many people that get into medicine, they get there because they don't like technology much. So the healthcare industry is sometimes slower to adopt some of those best practices over time. But I don't think there is a way to avoid doing the right thing. And the right thing in this case is ensuring that you have proper security. That includes authentication and validation of the identity of the individual. And as we said before, that might add some friction. Certainly, some of the things that we discussed, including the ability to use some biometrics to verify the identity, could be useful in that case. In other cases, using products that are out there in the market, like, for example, products that will validate your identity by asking you questions and allowing you to answer those questions accordingly, that might help. Perhaps being able to use a government-issued ID to prove that it's you automatically, of course. So you don't want to have a person trying to validate this. All those are valid methods, and all of those can reduce friction. But you need to understand what your target audience is. And because you need to target this broad range of people, well, you need to ensure that your products will, or whatever systems that you use to authenticate the individual, are meant to address that particular type of population, right? These are people that might be highly skilled and college graduates, or people that are blue-collar workers that never been to school in their lives, right? Or something like that. So you need to be able to ensure that anything that you do can work for either type of individual. Otherwise, you will be essentially limiting access to those people that cannot do that. The same thing applies to age groups. As we all age, we might not be at the sharpest point of our intellectual capabilities. So if you're asking them complicated questions about things that they don't remember, like, okay, what was the address of the first home that you bought in 1980, that might not be the best question for that person. So again, you need to tailor that verification process, the authentication and verification, to ways that can work for anyone. And in this case, it's truly anyone.
Well, and I think you make a really critical point. We think about this in software development all the time. We do a bunch of A/B testing. Which group of personas does a particular path work for? And I think this has been lacking in healthcare specifically. We think about when we think about patient personas, it's often patient activation models. Right? You've seen these, and you get sort of the Punnett square of how engaged are you in your healthcare versus how sick are you. We put you in a square, and then they treat you like that person as an analog. But it also needs to include the next step down, which, to your point in this case, what kind of access model works for you. And then ultimately, if I'm going to challenge that model from a security perspective and create a little friction, what kind of friction can you tolerate to get over that hump and get into care and get engaged? And so it presents another challenge for system designers and for CISOs and for patient program managers to really understand how you're going to get people into those spaces safely and make sure that the data doesn't get compromised. So it feels like a whole new area of study that might need to be developed as we think about how design is done. Right? It's really an integrative study on does your healthcare and your age and your socioeconomic status and your orientation to technology change the way healthcare should be delivered to you. I mean, it's just probably yes, but I don't know that there's a great school of design around that yet.
I think it should, but again, this is a completely new area for UX, right? User experience is.
I think there's all of this always comes back to the question of equity, right? It's sort of part of the intention of this podcast is to talk about places about how we build equity, and one of the issues is it tends to be underserved communities of color, communities with low access that are often preyed upon early by these new innovations. So you can create access. Hey, here's an easy way to do something. Here's a way to upload your data. Here's a way to scan in and use this. We'll give you a discount in exchange for that. And so this is always one of those places where we have to think carefully about making sure we're protecting consumers and patients and those who might be vulnerable to a new way of doing things or a new access methodology, but aren't going to be protected. Right? And to your point, this is a really good example. A low-end phone might not have the same security as a high-end phone, and only certain people can afford high-end phones. So what do you do when some of these things are accessible through a low-end or a low-cost phone in the Android ecosystem, or even not Android? A lot of flip phones are still running around out there. You've now created a vector, right, for entry that is this kind of data was never exposed before.
And it unfairly exposes more those people that are less privileged, right? The ones that are in underserved communities or people that don't have the knowledge to be able to make a better decision. So unfortunately, yes, there is a component of unfairness sometimes in this technological evolution.
I have this kind of, I'm going to start a list, and I'm sure my podcast manager is going to write this list down for me. So Syed, if you're out there, so shout out to Syed who's helping us run this podcast. This is number one, is kiosk-based data access for patients and consumers who don't have access to critical technology. I have this idea. It's not a unique idea, but that you could wrap a telehealth data access, medical records review, and coaching module into a simple kiosk at the edge of the CVS or in a grocery store. Quite frankly, in a little booth in 7-Eleven, right? It doesn't need to be anywhere special. And then you could access this through simple ID verification, and essentially give you a code and a PIN, give you a 2-factor authentication method, and allow you to go into that kiosk, pull a curtain, shut a door, and access your data, talk to an online health coach who could help you interpret the data, and then leave feeling like you have access to that data without having to put it on anything dangerous, right? And so we're talking to all of our friends at CVS and Walgreens and Rite Aid, and hey, we'll help. These are things like we can help, right? Is how do we create an access point for people who don't have access otherwise and keep their data safe, right? I think there's an opportunity there.
Adam, doesn't Higi have these little booths in grocery stores? Like, I think in public.
They do. And even, for a long time, we saw there were a lot of small MinuteClinic booths in a lot of pharmacies. But they didn't give you a data access point to look at your health data. And so I think this is the next iteration. I'm trademarking it. I'm patenting it. I call it dibs. But yeah, I think this is a place, right, where we've gone the telehealth route. We've proven it's sustainable. I think reimbursement has been renewed for most telehealth procedures. It continues to expand. But I think this is just another obvious thing: is virtual care should be more accessible. There should be a place, regardless of your socioeconomic condition, where you live, who you're born to, shouldn't change the fact you should have access to this data. So it feels like this is an opportunity, have a private spot to sit down. And this is, what telehealth has always been trying to promote. You know this as a physician and a surgeon, that we've tried to extend care in places where you can't get it to. And this is a way to do that, is to have somebody have a true, comfortable telepresence experience.
And we know that if we are able to do primary care, every dollar that we invest in primary care saves us thousands of dollars down the road. So getting primary care across everyone and everywhere is absolutely key if we want to improve our health system.
Agreed. And I think knowing that we're well under service for primary care physicians and that there's a shortage, this might be a way also to multiplex some of those primary care physicians and NPs and PAs and extend them a bit. There's an opportunity for sure there. Thank you, Flavio. It's really great to get a chance to talk to you. I know we have to talk work all the time. I have to bother you with critical things. We have to tell me something I don't want to hear, or critical decisions you have to do your job in.
You never bother me. Yeah.
And adjudicate. It's much better to get to talk just one-on-one and spend some time together.
It is. This is amazing.
So thanks for joining me today, and thanks everybody out there for listening. This is Healthcare DataWake.